Thank you for the invitation. I really appreciate the warm welcome I've received in Riyadh, and so thank you. So the topic I've been given is systemic mastocytosis. It's a rare disease, but I think in the next 15, 20 minutes, I want to convince you it's an interesting disease. So I have no disclosures. So the learning objectives are discuss recent updates to diagnosis and classification. Number 2, describe a practical approach to prognostication. And number 3, select a rational approach to treatment of mostly advanced mastocytosis. That's what I see in the clinic in hematology. So first, some background, because I imagine people may or may not be very familiar with the disease. So mast cells are derived from bone marrow progenitor cells. These cells are born in the bone marrow. They circulate for a short amount of time in the blood, and then they live in the tissues where the body comes into contact with the environment. So it's the skin, it's the mucosa of the gut, the respiratory tract. And we should be clear that mastocytosis is technically a malignancy. So it's a clonal proliferation of neoplastic mast cells. So what do mast cells do? Well, they have a role in innate immunity, but on the dark side, they also mediate allergic reactions, which can be very severe. So mast cells, we'll pretend the cell on the top left is a mast cell. It's a round cell, and it has these multiple granules, very basophilic granules. And these granules contain lots of mediators: histamine, tryptase, heparin, chemokines. So when these mast cells are triggered, they degranulate and they release these chemicals into the circulation, as you can see on the bottom right, and that produces the symptoms of mast cell disease. So when should one suspect that your patient has mastocytosis? Well, a fairly high proportion of patients will have a very characteristic skin rash, which is shown on the left. This is called urticaria pigmentosa. And these lesions are rich in histamine. So on the top right, as you can see, if you rub these lesions, many a times the histamine will be released and there will be a hive or an urticarial reaction, which is called Darier's sign. Mastocytosis patients also have other symptoms like peptic ulcer disease because of all the histamine release. They may have flushing because of prostaglandins. But the most severe complication is anaphylaxis. This can be life-threatening. Patients can have sudden circulatory collapse, syncope. This can be life-threatening. And it can be triggered by various things, some new drug that they started, an anesthetic that they received, or a insect bite, a bee sting or a wasp sting, something like that. So it's very important to educate every mastocytosis patient about this risk and make sure they know how to deal with it, how to avoid the triggers. And if the symptoms start, every mastocytosis patient should be prescribed two epinephrine auto-injector pens so that they can use it immediately to stop the anaphylaxis reaction. These patients can have also a lot of bone morbidity. So, accelerated osteoporosis, they have lytic lesions. These can lead to pathologic fractures. So let's quickly talk about the diagnostic criteria. This slide shows you the criteria. You have one major diagnostic criterion, and then you have 4 minor criteria. So to diagnose somebody with mastocytosis, you need to satisfy either 1 major plus 1 minor criteria or 3 minor criteria. So this slide shows you the major criterion. So these are sections of bone marrow biopsy, and on the top left you can see an H&E stain. Now it's hard to see, but what you should be able to make out is a cluster of mast cells, and it's actually a whorl of cells. At the periphery, you can see that these mast cells are not normal round-looking mast cells. They're more spindle-shaped. They're elongated with flat nuclei. And of course, the mast cells can be more easily delineated when you use sensitive stains like tryptase or CD117. And these stains should be used to assess the bone marrow biopsy sections in every patient that you are evaluating for mastocytosis. One of the minor criteria is demonstration of aberrant or abnormal expression on mast cells of certain markers. These include CD25, CD2, and most recently CD30. And this can be demonstrated either by flow cytometry or immunohistochemistry. A very important minor criterion is demonstrating the presence of activating mutations in the c-KIT receptor in mastocytosis patients. So the c-KIT receptor is the main growth factor receptor that promotes survival and proliferation of mast cells. And virtually all adult patients will carry that mutation highlighted at the bottom in yellow. This is the D816V mutation. It is present in over 90% of patients with mastocytosis, and it's considered the driver mutation for the disease. There are some other mutations also in other domains, but this is the main one. And the final minor criterion is demonstrating an increased serum tryptase level. So for the purpose of the diagnosis, the cutoff is 20 nanograms per mil, and it is fairly specific as long as you're measuring this at baseline, so when the patient is not having symptoms, and if you can show that it is persistently elevated. Okay, so now we've diagnosed the patient with mastocytosis. How do we classify the patients? So this slide is more complicated than it needs to be. I'll try and simplify it. So basically, there are two forms of mastocytosis. First is cutaneous mastocytosis, where you see the disease is only in the skin. And you almost never see this in adults. This is purely a pediatric disease. What the adults mostly have is systemic mastocytosis. So there, the mast cells involve the skin, but they also involve bone marrow and other internal organs. And systemic mastocytosis is of two broad types. There's the indolent mastocytosis, which is a low-grade disease. So mostly patients have nuisance symptoms, but no significant organ dysfunction. And then you have advanced mastocytosis. That itself is of three types. So one is aggressive mastocytosis, where you have organ dysfunction from mast cell infiltration. Number two is mastocytosis with an associated myeloid malignancy. So you might find mastocytosis with MDS or with CMML or with acute leukemia. And lastly, there is an entity called mast cell leukemia, which is extremely rare. So, one question when I started studying this disease is why so many disease subtypes? You have just one driver mutation, but then you have all these, disease manifestations. And the way I conceptually think about it is, think about patient one, okay? Patient one has only one mutation, the KIT mutation, and there's only one blood lineage involved, that's the mast cell lineage. So this is the patient who will develop indolent mastocytosis. In contrast, if you consider patient two, that patient still has just that one single KIT mutation, but now you have multiple hematopoietic lineages involved. And this is a patient more likely to develop smoldering mastocytosis or even aggressive mastocytosis. The extreme is the patient number three, where you have multiple mutations, so KIT mutations and other mutations, and also multiple lineages involved. And this is the patient who will develop mastocytosis with an associated myeloid neoplasm. So again, these are hypotheses. These are one way to think about the disease. So in terms of how do you determine disease subtype, what subtype does your patient have, there are just 4 steps. It's quite straightforward. So the first step is to make sure your patient does not have mast cell leukemia. That is fairly straightforward to do because your pathologist will exclude presence of very immature metachromatic blasts, etc. Once you've excluded mast cell leukemia, then the next step is make sure that your patient does not satisfy diagnostic criteria for an associated hematologic neoplasm, such as CMML, etc. So once you've excluded the first two, then you ask the third question, That is, okay, I have a patient with mastocytosis, do they have organ dysfunction? And I've given you the definition of organ dysfunction as per the ICC and WHO classifications. And if you satisfy those criteria for organ dysfunction, then the patient has aggressive mastocytosis. But if you exclude mast cell leukemia, if you exclude associated myeloid neoplasm, and if you exclude aggressive mastocytosis, then you're left with indolent disease. So how do you determine prognosis? Now, if you classify patients into the 4 major categories that I just talked about, you already have a good idea of the patient's prognosis. So these are survival curves. The curve in red are patients with indolent mastocytosis. These are actually the most common adult patients. So these will be about 45% of all mastocytosis patients, and they have a normal life expectancy or close to that of healthy controls. The middle 2 curves are patients with associated hematologic neoplasm or aggressive mastocytosis. Their median survival is about 2 to 4 years. And the 4th category, mast cell leukemia, you can barely see the curve. It's actually hugging the y-axis, and the median survival is only 2 months. So that's how aggressive this disease is. So, of course, the scientific community has worked to develop better prognostic models for mastocytosis. I can't go through all of them. I've listed some of the common prognostic models at the bottom of the slide with references. But the one we use at our institution is the one on the right. It's the Mayo model. And I like it because it's simple. All you need is the age of the patient and 4 simple parameters: the hemoglobin level, platelet count, alkaline phosphatase level, and serum albumin. And just based on that, you can risk stratify any mastocytosis patient into those 5 risk groups. And we tend to use this model in the clinic. So let's talk about treatment, and we'll focus mostly on advanced mastocytosis. So for this group of patients, you really need cytoreductive therapies. You need to kill the mast cells. Just symptomatic treatment is not enough. And in this slide, I've traced the timeline for development of mast cell cytoreductive therapies over a period of, 30, 35 years. So at the left, you start with the interferon era in the mid 1980s. Then the next era was when cladribine came on the scene. About 2001 was the first report. And then the right side of the screen, I show you the modern era, which is the last 10 to 15 years, with the development of very potent oral tyrosine kinase inhibitors that target that mutant c-KIT protein. There's also a role for stem cell transplant, and I'll discuss that briefly in one of the subsequent slides. So at the bottom right, you will see that in the United States, there are 3 approved treatments for mastocytosis. I won't talk about imatinib, we don't really use that, but the 2 other tyrosine kinase inhibitors are midostaurin and avapritinib. So when you compare avapritinib to midostaurin, I think avapritinib has some advantages in that it is 10 times more potent against the mutant c-KIT protein as compared to midostaurin, and it's also more specific. I wanted to share some of the data very briefly about the avapritinib trials because I think this has changed the treatment landscape. I think it has demonstrated a proof of principle that if you have a drug that can shut down that mutant c-KIT signaling, you can have a very potent anti-mast cell effect. I'm not saying this drug is perfect. It has lots of problems, but I think it has proved an important proof of principle. So the avapritinib approval came from 2 trials. This is the phase 2 trial. So advanced mastocytosis patients, 62 patients were treated at 200 milligrams per day, and the primary endpoint was overall response rate. So you can just look at that box at the bottom left. Overall response rate, 75%, but impressively, about 20% of the patients had a complete response. This is not something we've seen frequently with other therapies for mastocytosis. If you look at the middle panel, this was the secondary endpoint, which is change in the symptom score. So the symptoms significantly improved during treatment, and the patient's quality of life measures also significantly improved. Now this trial, of course, this was very short follow-up, only 10 months. So I want to show you some data from the phase 1 study, which also, data from this study was used for the licensing approval. And here, this was 69 patients, again with advanced mastocytosis. The follow-up was longer, 23 months. So this allowed for the responses to mature. And as you can see in the bottom left, the overall response rate, again, 75%, with a 36% complete response rate and 34% partial response rate. The time to response was 2 months, and the time to complete response, 9 months. And you can see the progression-free survival and overall survival curves on the right. Fairly impressive for patients with advanced mastocytosis. The middle panel shows you the very potent anti-mast cell effect of this drug. So mast cell aggregates, remember that was the major criterion, that was eliminated in 77% of patients. The serum tryptase level normalized in 74% of patients. And then look at the effect on the mutation, a very potent effect. So 30% of the patients had a complete molecular response, even when interrogating with a very sensitive PCR assay. So I think, fairly convincing anti-mast cell effects with this drug. So again, quickly to show you, along with the deep clinical and molecular responses, there was also improvement in bone marrow histology. So if you look at the panel on the left, at baseline you have dense mast cell infiltration in the bone marrow. You treat the patient, after 3 to 6 months, the bone marrow becomes hypocellular, but those mast cells now are only in the interstitium. Okay, you no longer see that dense infiltrate. And then after 6 to 12 months, the bone marrow is starting to look normal cellular, and the mast cells that were previously spindle-shaped now start looking round and normal appearing. So, the take-home message is that with avapritinib or avapritinib-like drugs that are going to come in the future, we have the potential for disease-modifying treatment. With avapritinib, we've seen responses regardless of the mastocytosis subtype, whether or not they received prior therapy, and regardless of mutational status. So let's say you have both drugs available, midostaurin and avapritinib. Which one to choose? Well, there's no direct head-to-head comparison, so we can only compare across clinical trials. But if we do that, then avapritinib has a 75% response rate overall, midostaurin anywhere from 20 to 30%. The anti-mast cell effects are more potent for avapritinib, but these drugs also have very unique side effects. So midostaurin, GI side effects, very prominent, nausea, vomiting, diarrhea, frequently lead to dose reductions, holding the medicine, starting it again at a lower dose. Also have to follow for QTc prolongation. When you think about adverse effects of avapritinib, the common ones are peripheral edema and diarrhea, but the ones of more specific interest are noted at the bottom of the slide, highlighted in yellow. So in an older patient, you really have to look out for cognitive changes, memory impairment, dizziness, sleep pattern changes, to even more severe cognitive effects. The other thing that was noted was this signal for intracranial bleeding. So the FDA label says that avapritinib is not recommended to treat patients who have a platelet count less than 50,000. And if your patient has a platelet count less than 50,000, you have to medicate, stop the avapritinib, maybe transfuse the patient, etc. But this is a significant barrier to the large group of patients who have an associated myeloid neoplasm and are likely to be thrombocytopenic from their disease. So again, avapritinib has neurocognitive effects because the drug crosses the blood-brain barrier, and you find high concentrations in the CSF. I just want to show in the bottom right that there are new tyrosine kinase inhibitors being developed that have minimal CSF penetration. And just one quick mention about cladribine. I think this drug still has a role for mastocytosis treatment. This is one recent trial, 79 patients, advanced mastocytosis. These patients received a median of 3 cycles. The response rate was 39% and no complete responses. If you look on the right side of the slide, the anti-mast cell effect is more modest. It's not quite as potent as avapritinib. But again, we use this agent because the responses are quick. If we need to debulk somebody quickly, we do that. Cladribine also has the added advantage of having effect against an associated hematologic neoplasm. And you know, can be used as a bridge to transplant. So one quick word about the role of stem cell transplant in mastocytosis. Very, very little data. This is the best data we have. 57 patients from 33 centers, and this was published in 2014. This was even before we had these tyrosine kinase inhibitors available. The main message is the overall survival in the top left was 57% at 3 years. But if you look on the top right, the best outcome was for patients who had an associated myeloid neoplasm. So let's say you have a patient with mastocytosis with acute leukemia or a high-grade MDS or myeloid neoplasm. Those are the patients that did best. So the overall survival was 74% at 3 years. And in this study, they found that, you know, myeloablative conditioning was better than reduced intensity conditioning. But again, in the tyrosine kinase inhibitor era, you know, the role of stem cell transplant is still sort of unsettled. And the last thing I'll mention is with the transplant data, there was this plateau in the survival curves. Now, again, the numbers are small, but there is a hint of that. So I'll end with this slide. This is the summary for the treatment of mastocytosis. I can share these slides with whoever wants them. You know, I can't go through all of this, but I'll just mention indolent mastocytosis because I haven't talked much about it. These patients are a real challenge. As I said, we educate these patients extensively on avoiding triggers for mast cell degranulation. These patients should carry an epinephrine self-injector at all time. With regards to management of symptoms, we do a stepwise escalated management, and we work with our colleagues in the allergy division. So, you know, histamine blockers, leukotriene antagonists, sodium cromolyn, in some patients, short-term corticosteroids. And in severe refractory cases, we have used cladribine, we have used midostaurin. Avapritinib is now FDA approved for treatment of patients with indolent mastocytosis failing, standard treatments. Perioperative management is very important in these patients because, you know, when they go through anesthesia, that can trigger a degranulation event. And it's important to address their bone health as well. So I know it's lunchtime. I'm sorry if I went too long, but it was a pleasure speaking with all of you. And this is my email if you need to contact.
Thank you.
Thank you.